Good day and welcome to Epstein, Becker, Green, and NEBGH Advisors webinar, The Impact of Value-Based Purchasing and Other Employee Initiatives on Population Health. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have 3 fantastic speakers today. Epstein, Becker, Green's Adam Solander, who is an associate in healthcare and life sciences practice, David Lansky, PhD, President and CEO of Pacific Business Group on Health, and finally, Laurel Pickering, MPH, President and CEO of Northeast Business Group on Health. At this time, I'd like to turn the webinar over to Adam Solander.
Great, and thank you so much, and thank you for everyone who's participating in the webinar today. We have 2 absolutely fantastic speakers that are truly on the front line of the employer population health movement. And I'm also really excited about today, not only because of the speakers, but from my perspective as a benefits attorney, this is really the exact time to talk about these issues. I think since the ACA was passed back in 2010, many employers, if not most employers, and those who provide advice to employers have been mostly focused on the compliance obligations around the law. What this has resulted in is that many employers have enacted benefits amendments, modifications to their plan that were made to mostly comply with the law and weren't necessarily focused on quality or understanding what the long-term implications of those changes would be on their plans in terms of cost and in terms of quality. You know, what I always equate this to is, because it's almost Thanksgiving, I like to use an analogy that employers, for the most part, have just gorged themselves at this ACA table. Their plans are now fat with all the mandates that they've absorbed. And now that the employer mandate is set to be implemented, most of the compliance obligations that are on employers are going to be implemented. So it's time for most of us on the call to look at our benefit structures and get them in shape, so to speak. It's time to hit the treadmill. What that means for most employers is that it's time for us to take a long look at our benefit structure and make sure that the offerings that we're offering meet the needs of our population in terms of both quality and cost. Where this is really going to be punctuated is starting in 2018, the Affordable Care Act has a provision called the Cadillac tax. And basically what this provision does is it taxes the excess costs of plans over certain thresholds. So in 2018, if you have a plan that exceeds the thresholds, which are $10,200 and $27,500, there's a 40% non-deductible excise tax on the amount that exceeds those thresholds. So if you're offering individual coverage and your plan costs $11,000 per employee, there's a 40% tax on the $800 that exceeds that $10,000 threshold. And while this seems like a lot right now, because of certain facets of this provision with the indexing and other facets of the provision, this tax is going to affect a lot more employers than originally thought. And the end result of this for employers, and I guess why we're on the call today, is that we need to come up with ways in which to lower the cost of our plans to avoid these penalties. I think in the end, if we're not able to avoid these penalties, it's unlikely that employers will be able to offer coverage to employees without providing any additional benefit. So the benefits will cost more because of the Cadillac tax, and our employees won't receive any additional benefit. What this ends up doing is it really puts a highlight on the fact that we need to get under these thresholds. We need to come up with ways to break through a lot of the ACA mandates that were put in place. And what we're talking about today should really be the main focus of any employer strategy to avoid the employer mandate. In my opinion, the best way to really deal with these strategies and lower plan costs is to lower the cost of your population, to get them healthier, so to speak. The speakers that we have today are really the people who are on the front lines of this, and I'm really thankful that they're willing to share both their time and their experiences with us today on population health and what employers are doing in this regard. So turning to the slides, this session will explore the activities of some well-known employer coalitions and discuss how they're designing and implementing value-based purchasing initiatives. The speakers will provide an update on consumer-directed healthcare organizations and care management and wellness programs. The bullets here are what they're going to cover, and we're really thankful for that. So I will introduce the speakers in order in which they're presenting. The first speaker is David Lansky. David is the president and CEO of the Pacific Group on Health. In that role, David directs its efforts to improve affordability and availability of high-quality health care. Since 2008, David has led a coalition of 50 large employers and healthcare purchasers that represent over 3 million Californians, including CalPERS, and many of the state's major employers. David is certainly a nationally recognized expert in accountability and quality and measurement in health IT and sits on the boards of numerous healthcare companies. He is also a very prolific writer in this area and has authored over 30 peer-reviewed papers on outcomes research and quality measurement. Our next speaker is Laurel Pickering, who is the president and CEO of the Northeast Business Group on Health. The Northeast Business Group on Health is a 200-member business coalition that represents over 1 million covered lives. The Northeast Business Group on Health is committed to market-based healthcare reform, quality improvement, and value-based purchasing. During her tenure at the business group, Ms. Pickering has focused on mobilizing the business community to drive improvement in healthcare and providing access to health insurance for small businesses by creating a healthcare exchange. She is truly a nationally recognized authority on trends in innovation and health benefits and has held leadership positions in the industry, including work for the government with the Centers for Disease Control and Prevention. So welcome to both of our speakers today. Thank you so much for participating, and I will, at this point, turn it over to David, our first presenter.
Thank you, Adam, and thanks to all of you for joining and the chance to work with Laurel on this. We cover the two coasts, and we have some of the same interests and challenges, and I'm sure you'll find some complementary ideas from both of us. I'll go through some material here. What I'll probably try to do is primarily focus on 3 or 4 examples of what large employers are doing to drive value through the market and to improve the health of their populations. And hopefully those examples will tee up some discussion that we can continue with. As you see on the first slide, PBGH is a nonprofit association, and our focus is on transforming the healthcare system as a whole. And in the course of doing that, of course, we hope our members will get some benefit. The next slide. The next slide is kind of a roster of who we work with primarily. It's a relatively small group of about 50 or 60 large employers. As you see from the brands, they are mostly not regional employers anymore. They've mostly become parts of large national entities. So groups like Walmart and Wells Fargo and Boeing are everywhere. There are also some interesting partners here, including Covered California, which is the health insurance exchange in California. And they see themselves as a value purchaser, and other exchanges, of course, are exploring how, once they get up and running successfully, how they can be active in driving some of the same objectives as the private purchasers, and they would like to share best practices with both our public and private members that we have. Next slide. Just a couple of slides to state the obvious to everybody on this call. The employers look at these trend lines and they see this inexorability until the recent moderation in trend. And their exposure, even though there has been some cost shifting to employees, they still have a very high burden on their own program. Next slide gives a little more of a personalized tone of this. It's just astonishing that the actual absolute dollar amounts, as we look at them for family coverage, as you see on this slide, pushing past $16,000 a year. If you imagine yourself as an employer of people with very modest and moderate wages, like a clerk at a Safeway or a Walmart, probably a half or a third of your total compensation is now going to the healthcare system. And obviously there's been flattening of wage growth in the United States, largely attributed to the deflection of income into the healthcare system. And so the employers are looking at this and really seeing it as unsustainable unless there's a substantial reduction in cost. Most of our companies have been at this for 20, 25 years and really believe for a long time that focusing on quality would lead to cost moderation. And just in my meetings with them in the last year or so, I think they're taking a different tone, which is that we have to really work the cost angle in parallel with the quality angle, the value equation, but that working on quality alone, which was our MO for a long time, is not sufficient right now. Next slide. So as a result, you see now 3 years running of this national survey showing essentially the same result, which is that only about a quarter of employers are saying that they think they'll still be in this business in 10 years. And I think the message of this, obviously this is an opinion survey, doesn't mean they'll necessarily be abandoning the benefits role, but I often talk with providers and try to encourage them to think hard about what it would mean if the private employers left the commercial insurance world, began to move toward a flat defined contribution, maybe into private exchanges and other mechanisms of limiting their financial exposure. The abandonment of the benefits model by the large employers would really pull out most of the margin that providers live on. And it would move us toward what is effectively a government-subsidized and government-sponsored health market, with all the implications that probably has for both political influence and cost management. So I think the employers see this as we're entering the last 10 years of the opportunity to sustain employer interest in healthcare. And most of the strategies I'll summarize for you today are examples of what the employers who want to stay in the healthcare business are thinking as the mechanisms to make it sustainable. But it's really on they're coming up to the edge of the cliff. And many of our members have a great deal of pressure from their bosses to put a limit on the growth of healthcare spending, and otherwise that they will be abandoning the healthcare marketplace fairly soon. Next slide. So over time, our members have really had 3 phases of commitment. For a long time in the 90s, they believed in managed care, and they believed that working with the insurance carrier would be the pathway toward stabilizing cost and improving quality with all the tools like HEDIS and CAPS and disease management and so on. In the 2000s, our members moved fairly quickly toward account-based plans, consumer-directed healthcare, the belief that consumers controlling a larger share of spending would lead to moderation in cost and potentially improvements in quality. And now in the last 2 or 3 years, I think there's been a shift among my members toward provider relationships and believing that only through re-engineering of the delivery system will we see sustainable improvements in cost and in quality. So all these are not mutually exclusive, and in fact, we work closely with the health plans. We continue to work with benefit design to influence patient and consumer behavior. But the interest, as you'll see in my examples of working directly with providers, has really grown, although it raises some difficult challenges as well. So this last bullet point here just emphasizes some results of recent surveys that NEBGH and others have done, that the 2 arms of the strategy right now are payment reform, that is, employers working directly with providers to change what they get paid for and how they're incented, in parallel with consumer benefit design and steerage to use the financial responsibility patients now bear in a way that helps them choose high-performing, high-value providers. And I'll show you examples here. Next slide. So I'm going to give you 4 short stories. 3 of them are examples all from one clinical domain, from orthopedics, just for the sake of a consistent set of illustrations: reference pricing, travel surgery, and patient outcome measurement. And then the 4th is an example of an ACO strategy, which wraps up this to a less of a clinical episode level and more to a population level. I'll just go through those quickly. Next slide. So CalPERS, which is the agency that administers both state employees and other public employees around the state, it has 1.5 million covered lives, so it's very influential in California. They took a look about 3 years ago at what they were paying for orthopedic services, particularly joint replacements. They observed that in their PPO programs, they were paying a range from $15,000 to $110,000 for the same procedure, for a primary joint replacement. And the decision was, of course, up to the employee. They had an open PPO model. They could go anywhere they wanted. They went to whatever their doctor recommended in a convenient location. And then the bill shows up at CalPERS' door, and sometimes the bill is $15,000, and sometimes the bill is $80,000, and there's no rhyme or reason to it, and there's no association with quality outcomes or anything else except essentially random patient decision. So they decided they could set a threshold price of $30,000, a reference price, which under that amount, that is for any facility which typically on average was charging under $30,000, the patient would receive normal benefit coverage under their PPO plan. But if the patient chose to go to a place which charged more than $30,000, they would bear the total cost of the difference. The next slide gives you a graphic representation of what happened. And it's not hard to see what date this was implemented. It's rare in any of our work we see such a dramatic shift in behavior. But that bright red line was the percentage of patients going to the over $30,000 priced hospitals. And it just dropped rapidly, starting with the initiation of the program, and then stabilized at about 35%, as you see, after 2011. The next slide, the overlay, shows what happened to pricing. And similarly, the high-priced hospitals that you see were averaging about $45,000, that red line. As soon as the program was implemented, their price dropped surprisingly just below $30,000, so that they would no longer be an excluded high-priced hospital. And it's interesting also to note that other hospitals in the state saw that signaling and also made a drop. You see the blue line, the other Anthem Insurance, Anthem Blue Cross covered hospitals also dropped their price, not as dramatically, but they dropped it. So the overall effect of this was about a 27% shift in patient steerage where they went, and about a 20% total decline in the cost of the orthopedic service line as faced by this employer, by CalPERS. The lesson from this was, without changing payment, simply by changing at the margins the recognition by patients that where they went would cost them more money, CalPERS had a very dramatic impact on the market as a whole and on their own costs for this particular service line. So that's one strategy, is working through the benefit design to affect patient behavior and in turn affect the market. Next slide. The second model is to use also benefit design, but to focus very strongly on quality rather than simply on the price. So in this example, 3 companies we work with, Walmart, McKesson, and Lowe's, got together just about a year ago and decided they would create a national travel surgery network. Next slide. They focused this on creating a bundled payment for total hip or total knee surgery. The patient, in this case, say a Walmart employee, if they chose, could take advantage of this program. It's entirely voluntary for the patient. And they could say, I am willing to travel to one of these designated centers. If I choose to do that, I will have no cost sharing, and I will have a family member go with me, and all the travel and hotel costs will be paid. And I'm having the opportunity to go to a world-class center of excellence for my care with a much improved likelihood of a good outcome and much reduced likelihood of a bad outcome. The fees for the payment of this were developed jointly through negotiations with the providers. They were designed to promote coordination both pre and post travel and during, of course, the episode of care. It was entirely aimed at getting fair pricing, not low pricing. It was not a heavy-handed, drive the price down negotiation. There was, as you'll see in a moment, a very strong recruitment based on the quality of the program first, in the belief that high-quality programs will, in the long term, be cost-effective. And it wasn't appropriate to negotiate a tough price at the front end. It was more appropriate to know that we're going to have a low complication rate, a low reoperation rate, a low revision rate for these joint replacements. That would be savings to the employer and benefit to the employee in the long term. Next slide. So the value for the employee was a high assurance of very high quality care compared to what might be available in the community. An integrated care experience with the local providers and the remote providers, a very strong patient-centeredness focus, which you'll see in a moment, and essentially no out-of-pocket cost to the patient and family by taking advantage of the program. Next slide. For the employer sponsor, they get extremely high patient satisfaction. Patients love this program. The cost, because it's a bundled price, is now predictable. That is, more risk for any adverse outcomes has been shifted to the provider center. Long-term savings because of the very high likelihood of improved outcomes. In fact, the models we've been running, there are 3 and 4 times lower rates of complication and reoperation for these centers of excellence than what is available typically in the community. So the likelihood of savings in reoperation rates is very high. And generally, we were initially modeling an ROI to the employers of less than 24 months, but it's actually much faster than that as it turns out. Next slide. The criteria for selecting a center of excellence in this program, you see there are 3 categories of criteria we were looking for. Obviously, the employer's need had to be met. That is, had to be a reasonably convenient location for their employees, wherever they might be. We wanted the bundled payment and the capacity to accept bundled payment, which turned out to be one of the tougher criteria. Having some experience taking patients in from remote locations and knowing how to support them well. And then their ability to report on performance, which, as you know, for employers is a very big criterion. And we really wanted to see evidence of high performance on patient-reported outcomes and patient experience measures, as well as total cost. On the quality of care criteria, we did a very extensive national search on all the data we could find to evaluate outcomes, including, frankly, down to the surgeon level. That is, some surgeons within a center are permitted to be in the program and some are not. We had to see surgeon-level outcomes and quality data, the volume training and experience of those surgeons, patient safety and satisfaction scores, and their commitment to evidence-based practice. And then from the patient experience point of view, we really wanted to engage patients. They have to be part of a shared decision-making exercise at the outset. They have to get a lot of supported resources, including kind of concierge care. And care, I mean, a lot of our members are very concerned about the patient experience. They want to have these folks come back happy with the entire experience that they've been going through. Next slide. In this process, about a year ago, we recruited 4 centers around the country. You see they're geographically dispersed, in part to respond to where the workforce of these employers was concentrated. One of the interesting features of this model is that you see a Kaiser Center in California as one of the 4 centers, and that's very unusual. As you all know, Kaiser has historically been a capitated model and a closed system, and has not been the kind of structure which could receive patients from across the country under a PPO or a self-insured basis. But I think Kaiser also sees this as a time in the evolution of the market when they have opportunities to use their very excellent programs in ways that are new for them and new for the market, which also sends a signal to community providers, in this case in Southern California, that they, in a sense, have a new competitor that they have to be capable of responding to. We are now adding additional locations in other geographies, and we're also adding a spine surgery program for 2015. Next slide. And just to keep a snapshot in the first 9 months, we had over 1,600 patients who said, I'd like to get surgery under this program, just from those 3 employers you saw. We've already completed over 300 surgeries. And I put this in just as a tagline to say that we didn't expect in orthopedics that there'd be a high rate of inappropriate referrals. We understood we got into spine or heart, there may be higher rates of potentially inappropriate care. And we were relying on these very strong world-class centers of excellence to make good judgments about who was appropriate and who wasn't. But we didn't think that would be the case in orthopedics, but it turns out it is. We are having a non-trivial number of cases showing up at the door of these travel surgery programs who really aren't appropriate for orthopedic care. So obviously the patients are not likely to benefit from surgery, so it's good they're being counseled appropriately. But it's also an unexpected source of financial savings for the employers that some of this inappropriate care is not being performed as it might be in the community. Next slide. The third example I'll give you in this orthopedics trifecta is the employer's commitment to creating an outcomes registry for this procedure, this set of procedures. I think what's unusual about this is that the employers were the founders of this registry. They said, we don't want to just refer our employees to any place in the community that has an orthopedic surgeon. We want to refer them to people who are good, because we want good outcomes. We want people back at work, productive, healthy, satisfied with the experience. And as a result, they started about 3 years ago working jointly with the California Orthopedic Association, that is the surgeons, to develop a Level 3 Joint Replacement Registry. As you see now, it has about 37 sites accounting for 40% of the cases in California. We also have a collaborative relationship with Kaiser, which is another 10 or 15% of the cases in California. So we're getting close to 60% of the cases being captured in either the Kaiser registry or this community registry. And it's continuing to grow. Next slide. Is not only capturing device information, which most registries, of course, focus on, but it's also got this very strong emphasis on patient-reported outcomes. So much as was the case with the travel surgery program you just saw, the employers insist that any partner they're going to work with be measuring preoperative and postoperative outcomes. Next slide. This just shows you the case volume going up to about 10,000 cases so far in the registry in California, doubling every 6 months. Next slide. But I wanted to emphasize that we have a series of technology platforms to capture patient evaluation of their functioning and pain and disability level prior to surgery, and then at 6 and 12 months after surgery. And we're now just compiling the data on how hospitals compare on their ability to improve functioning, which is the gold standard for employers. A lot of the other process measures and other indicators that are part of the quality measurement enterprise we're glad somebody's looking at that, but it's not what the employers really value. So this is the real primary selling point of the California Joint Replacement Registry. Next slide. The key feature here is to have the insurance companies use this data as part of their product definition. What we like to see as employers is for the carriers to help steer patients to providers who initially commit to collecting data about patient outcomes and then, in time, actually perform well at helping people get good results. So as you see on the slide, we're working with the major carriers in California to have them include this information in their recognition programs and their tiering programs and favor those providers who capture the data and perform well. And I've talked to a number of small hospitals who've said, we're joining the registry because we're afraid if only the big hospitals do, we won't have any cases. We're going to see the big hospitals who participate in this and do well in it be favored in the referral patterns and the tiering system, and we need to get in that game, which is exactly the result we're looking for. Next slide. So just to summarize all that, I think the key takeaways I'd suggest from what employers are looking for, and I think it applies to a number of services and episodes of care, but I'm using orthopedics as a case study. They like bundled payments for a standardized, well-defined episode of care. They expect there to be accountability for outcomes, and those have to be defined, ideally in collaboration with the providers and medical societies and patients. They expect there to be tight coordination across the continuum between the primary care, referring physicians, and the follow-up care. We're looking for transparency on both quality and cost, including a comprehensive quality dashboard that includes patient experience, patient outcomes, clinical outcomes, and cost. One thing I didn't mention with the travel surgery program is we require those 4 centers to meet with each other about every 6 weeks and talk to each other about quality strategies. So we're really getting some of the best providers in the country sharing their capabilities with each other and learning how to manage these cases to the best outcome. We're really excited about that, and I think they've been excited to have the chance to work with each other on care improvement strategies, so to continue to improve the best care and make it even better. We expect participation in registries with public reporting. One key feature of that California registry I mentioned is the hospitals are required to report their outcomes publicly. So unlike most registries, which are primarily for professional benchmarking, we expect this to be a public system. And then I mentioned shared decision-making earlier, patient outcomes, patient experience. We see all of those as part of this process of bringing patients into the center of the care process and having them really understand and be involved in their own decisions. So that's a summary of sort of taking on a clinical episode from a purchaser point of view. Next slide. Let me just shift gears and talk about ACOs. The graphical display on the right here, you see about 4th down is the rate of commitment by employers to ACOs, and it's not that high. You see on this slide about 28% say they are likely to be moving through ACO contracting. And I often talk with ACO audiences about why is that? Why is it that the ACO, for all of its potential attractiveness to an employer, is getting a moderate but not passionate response at this point? And a couple of the features are over here on the bullet points. Our members, at least, don't have a uniform belief about where the healthcare system should end up. There are quite a range of strategies and philosophies among large employers. They all want to move toward value, but they don't know yet what's going to deliver value. And maybe ACOs will be a piece of that puzzle, but we don't know yet. So we're taking a fairly agnostic or cautious view of the evolution toward integrated systems and ACOs. I would say, to summarize that, I have what I call the consumerist groups among the large employers who really believe in the shopping paradigm and giving consumers an account with money in it and letting them go pick their doctors and hospitals and providers as they think best. And then there is the integrated care faction within the large employers who really believe that we need to encourage integrated care systems that are accountable for cost and quality and can build the integration across the continuum to best serve the employees. That's not a resolved debate. So I think the faction that is going more aggressively into ACO contracting will test the hypothesis that we are ready for an integrated care model that perhaps we weren't ready for in the 90s. So purchasers are very diverse. They have different belief systems, different strategies. They have different resources internally. They don't all want to go down one path. And they're also recognizing that the market's changing rapidly. And as I mentioned in the example of Kaiser being part of the Centers of Excellence program, we're going to continue to see all kinds of new models of care and financing and business relationships, and we want to encourage that. In fact, one of the jokes we have at PBGH is that the only thing all of our members have in common is their desire to disrupt and innovate, but they don't have a common belief about how best to do that. So let me go on to the next slide and talk a bit about ACO strategies. The big decision for most large employers in considering an ACO partnership is whether to build it or to buy it. On the plus side of building an ACO, they can handpick the providers, much as you saw in my travel surgery example. They can control the design elements, what care management functions, what metrics to hold the system accountable for, who gets paid what under what basis. And they can design it for their population or their geography. That's advantageous. Some of our employers, Intel, for example, in the Albuquerque market, has followed many of those criteria in designing just what they want in the way of a service platform. The difficulty is it takes a lot of resources and staff by the employer to sort that out. There are very few employers in this country who have the capability of doing all that work. It's also not sure that they can sustain that effort and that the model is going to be successful and sustainable after that effort, after that level of effort, because there's not as many players at the table to keep it going. The alternative is to go to a large health plan, and obviously many of the health plans are now offering ACO frameworks. That's a much quicker startup. You can build upon the management capabilities and infrastructure that's already in place, and you have a larger network of providers within which to benchmark. The difficulty is you can't customize it to your own needs as much, and that's obviously what many of the large employers would like to do. Next slide. So right now, if you talk to my members at least about ACOs, about 7 or 8 of our 50 companies have been developing direct ACO contracts, so it's a small but important number. Their general sense is there are not as many strong ACOs out there as the branding would make you think, that when you really get under the covers, the capabilities are a little thinner than what is needed. Their job as employers, as purchasers, is to set the standards, raise the bar, make the performance requirements simple, compelling, but achievable. And they follow these 7 or so principles: transparency, a focus on outcomes, a focus on patient-centeredness, focus on quality, not quantity, in terms of provider payment. That is, the purchasers want to dictate how the providers are paid within the ACO, which can be a point of attention. A focus on affordability and sustainable cost trends. A concern about consolidation, and that is a preference for competing ACOs, where ACOs are competing with each other so that no one is achieving excessive market dominance and the ability to set prices. And then use of HIT and information interoperability, in particular in care coordination through IT. They recognize that getting all that is going to require a lot of work by the employer. They can't just go out and sign a standard contract. And I'll give you an example here of one of those projects in a second and what it took to get it successfully off the ground. They also understand it's going to take multiple years. It's a sustained commitment, and it's an evolution toward global payment and provider risk, which is where those who support the ACO model would like to go. Next slide. We have been working jointly with the Catalyst for Payment Reform to produce a toolkit that amplifies on what I just summarized for you. And you can go to the website that's noted here and download all these components: model contract language, model performance measures, a user guide in terms of the financing models, a readiness questionnaire you can take to see if you think you meet what the purchasers are looking for. So this is a purchaser lens on what ACOs need to do to be attractive to us. Next slide. So to give you a case study, this is the City of San Francisco Employee Program. It's about 110,000 covered lives. They wanted to move toward an ACO, and they wanted to move toward competing ACOs. So they actually worked with 2 health plans and their associated provider systems to create 2 ACOs, and then let the employee choose whether they would prefer to be in the either the two ACO groups within the Blue Shield product as it plays out in California. In parallel, Kaiser is still being offered. As you see, it covers almost half the workforce available in that. So in effect, they have 3 ACOs. If you think of Kaiser as a pre-existing ACO type model, and then the 2 new ACOs under the Blue Shield structure, dividing up those other 40,000 lives. Next slide. But what's important, I think, to look at this activity are a couple of things. One is this is B&T, stands for Brown and Toland. You see them there at the bottom. That's a large medical group in the Bay Area. In this case, Brown and Toland and the Sutter Health Hospital, California Pacific Medical Center, work jointly under a Blue Shield insurance program to service the city and county of San Francisco employees. This spectrum of activity from left to right was the initial laundry list of program interventions that the city wanted to see implemented through the ACO model. So in a sense, this was the shopping list that they came to Brown and Toland with and said, we want to see 7 days a week ED care management teams. We wanted to see weekly interdisciplinary rounding on inpatients and so on. And they added the items in blue, this is in 2012, to the existing services that were comprising the ACO spectrum of care. And all this required, at the early stages, weekly meetings between the employer, the provider system, the hospital leadership, the insurance company, to drive this model along. The same story would be told by CalPERS, which implemented an ACO in the Sacramento market. It was very detailed program planning jointly with the purchaser and the provider. Next slide. The results were positive. As you see here, they had reductions in readmission rates, reductions in length of stay, reductions in ER visits, slight increase in admissions. And these have been sustained over a couple of years now. So overall, this has been a successful intervention in terms of utilization. Next slide. But it's a long-term collaboration. You see year by year the stages of work and the continuing complexity of the program as the groups get their feet on the ground with it. So I think the highlights of this is it's doable, but to meet the employer's requirements took a great deal more than what the existing delivery system had already put in place and required a close partnership to make it really come to fruition. Next slide. So to summarize what I observe in the large employers' attempts to move toward population health through purchasing and benefit design strategies, the large employers we work with have an interest in disruption. They basically don't believe you can buy it off the rack. They need to work with partners who want to change the delivery model, are willing to accelerate new payment and delivery models as part of that process. The employers generally don't think that the bar, the performance bar, that the delivery systems have been articulating are high enough, whether it's on the cost thresholds or on the quality performance. When we went out to do the travel surgery program and we used very stringent quality criteria and found 4 centers around the country that met our goals, I got a lot of calls from other hospitals saying, why can't we be in this network? And essentially the answer was, if you can meet the criteria of a Johns Hopkins or Virginia Mason, we'll be happy to start that conversation. But we are going to encourage patients to go where they can get the level of care we know is possible. And we feel like our job in the market right now is to highlight those high performers and encourage care to go there. We are interested in direct relationships with aligned provider systems. By aligned, I mean those who share the same goals and values. We also don't think there's a single silver bullet. Just changing payment won't make this change happen. We have to also change how consumers experience their cost sharing and their benefit design. We have to also change the flow of information so we really have meaningful outcomes data. And we have to engage the providers in clinical improvement strategies that drive toward better outcomes. And then finally, the large employers realize they have to put a lot of their own skin in the game. They've got to put their own staff and consultants and dollars and patients into the process of testing, spreading, and scaling innovation. So I think that's the end of my remarks. Any more slides? Let me see the next slide. Yep. Well, thanks for your time. I'll look forward to some conversation and hand it over to Laurel.
And this, Adam, let me interject. If you have any questions, there's a Q&A portion on the right side of your screen. Please feel free to enter all your questions, and we'll address them right after Laurel's remarks. Thanks. Laurel?
Okay, great. Thanks, Adam. Thanks, David. It's great to be on a webinar with David. I like his reference to, anchoring both coasts here. And I think our presentations are very complementary because David gave you an excellent summary on where employers are at, especially the large employers, and what they're doing, what the employers are doing. And I'm going to give you a look at what our coalition is doing, working with the employers to drive value in what they purchase, both from health plans and the delivery system. So I think it was a very nice complement, the way this worked out. So similar to Pacific Business Group on Health, Northeast Business Group on Health is a nonprofit business coalition. We're a little bit different from PBGH in the way that we have all the stakeholders as members of the Northeast Business Group on Health, and that's actually critical to how we pursue value-based purchasing and, changing the delivery system. So we have employers, providers, insurers, and other organizations working together, and we are in New York, New Jersey, Connecticut, and Massachusetts. But we are employer-led. I mean, our board is, the majority of our board are purchasers of health care, and we're an employer-led coalition. Our mission is to empower our members to drive excellence in health and achieve the highest value in healthcare delivery and the consumer experience. And we actually just worked on our mission this year, and it was important for us to include in that, improving health, improving healthcare delivery, and then ultimately it's all about the patient and their experience. So, so we got all those things into our mission. So next slide. So this is a sample of some of our members, employer members, and you can see, similar to David's, ours are mostly national and many are global self-insured companies, and these are names that I'm sure many of you recognize. Next slide. So what I'm going to focus on in my remarks is how does the business group empower our members, give a couple of examples of that, and then how do we at the business group use that power to drive, to really drive our mission, excellence in health and healthcare delivery. Next slide. So the first category, empowering our members, I'm going to talk about what we do around health plans and then just touch on education. So, employers right now, although as David said, it's changing, but for the most part, the employer's biggest lever is with the health plans. And so at the business group, we focus on how employers can work with health plans to improve the health of their employees as well as the value we get from the delivery system. And we have two ways that we do that. One is through a health plan evaluation process called Evaluate, and I know that Pacific Business Group on Health also participates in Evaluate, so this is a good example for both coalitions. And we have user groups. Right now we have an Aetna, United, an Anthem, and a PBM user group. And we do a ton of education, and really what we feel our role is to provide the employers with tools to run their benefit programs most effectively, but also provide leadership and to really direct them on how they can put their purchasing leverage to work to improve value in the system. And we've done programs, for example, these are some of the topics we've covered: working directly with providers, which is what David just presented, private exchanges, specialty pharmacy, healthcare innovation and disruptors. We've gotten very interested in featuring new companies in the market, startups, companies using technology in new ways, the ROI of wellness programs, retail clinics, et cetera. We did 40 educational programs in 2014. So this is one of the ways we think is critical to empower employers to purchase on value. So I'm going to spend a few slides on Evaluate, because I think this is the best example of how we are, driving value and population health, at the business group with our members. So Evaluate is a health plan evaluation process, And it's evidence-based, so we use measures and metrics that, are standardized nationally and based on evidence from NCQA, from CDC, from Leapfrog, from Catalyst for Payment Reform. I mean, trying to align ourselves with what's happening nationally and what we know works. And the focus of Evaluate, which is different from other consultant RFPs and RFIs, is that it specifically asks or gets at, how does the plan use the information and the resources it has to improve the health of the member, and how does it use its contracts to improve with providers and hospitals to improve the delivery system. It's sponsored by the National Business Coalition on Health, which is the umbrella organization for all the coalitions like mine and David's around the country. And this year we had participation from Aetna, Cigna, United, Anthem, and I actually left out, we had one upstate New York health plan, CDPHP, also participate. So I don't want to forget mentioning them. And, David maybe can comment about who participates in California. David, do you want to just mention, do you know offhand?
I don't know offhand. I know we have one major plan that does not, which is an issue for us, but I don't have the whole list of who else is in.
Okay. So I know that, as I said, this is an initiative that, it's very important for us at the business group to have all the national plans participate, because that's mostly, who our members are using. So the process that we go through is that the health plans fill out the RFI, and it's hundreds of questions, and it takes them, we give them a couple of months to fill it out. And it takes a long time because it's different from every other RFP and RFI that they complete. When we get the RFIs back, we score them, and we give detailed feedback to the plans and to the employers that are our members. And the feedback is, for the plans, is a roadmap that tells the plans, where they didn't meet our expectations and how they can improve, and we give them detailed feedback on how they can improve. And we also give them their competitors' information at a high level so that they can see, how they performed compared to their peers. And, we have found that that's been, of great interest to the plans because they're obviously very competitive. Then we sit down with each of the plans with their leadership and our members, and we go over the results. And often from the plan, we have in a room, the medical director, the head of quality, the head of pharmacy, the head of behavioral health, any subject matter expert that touches the content of the RFI. And the areas that we question the plans on are disease management, and we almost always cover diabetes, cardiovascular disease, and then we rotate a third condition like back pain, COPD, asthma. Prevention and health promotion is another section, and in here there's a big emphasis on smoking cessation and weight management. Consumer engagement is another whole category, pharmacy management, behavioral health, and then provider measurement and management. How does the plan measure the quality and value of the providers in its network, and how does it share that information back to the members and to the employers? So if I could have the next slide. I thought I'd just give you a couple of samples of what does the output look like from a high level for the plans and for the employers. So this is an example. This was 2013, and this is one section of the Evaluate RFI. This is the consumer engagement section. And when you see the key at the bottom that corresponds to the colors of the bars, in the consumer engagement section, we ask the plan, first of all, what are their plan design capabilities? And this is a reference to value-based benefit design. What capability does the plan have to implement value-based benefit designs? Provider information is, what kind of information does the plan provide to the member to make a decision about picking a hospital or a physician. That's quality information and anything else that's relevant. Treatment option support and personal health record, and this is, how does the plan help the member when they have a diagnosis, work through what are my choices and what path do I want to take for treatment. And then price transparency, what does the plan's price transparency tools look like and how good are they? And then performance measures, and this would be for consumer engagement, this would be the CAHPS measures, the Consumer Assessment of Health Plans measures. And so here we see in 2013 we had Cigna, United, Aetna, Anthem participate, and we had some participation in New York and New Jersey. And you can see how the plans line up and how they've performed compared to each other. What you see all the way on the right, where we have PPO benchmark and possible points, the PPO benchmark is the plan in the country that participated in Evaluate that scored the best. And the possible points show you, how the breakdown of all the points, by category breaks out. So one of the things that's interesting is that you see we show the plan in the country that performed the best, which says to the plans, there is a plan out there that can actually do this and does better. And when we initially did this many years ago, we've been doing this for 8 to 10 years, we had plans say to us, why can't you just, give us the average of the plans and compare us to the average plan in the country? And, we had our employers stand up and say, we don't want average, and we are going to compare you to the best plan in the country and expect you to strive to be where that plan is. So if I could have the next slide. This is chronic disease management, the same year, the same plans. And the key at the bottom shows you that we measure them on how they support the member. Once they've identified a member has a chronic disease, how do they, put them into, stratify them by risk, put them into an appropriate program, coordinate the interventions that they're receiving, and then how do they ultimately support them to manage their chronic disease. The next category, how does the plan support the physician or the practitioner by providing them with information that can help them better manage the patient, because there are things that plans know about patients that physicians don't necessarily know, especially when it comes to medication and medication compliance. So CAD is cardiovascular disease performance, and we have diabetes performance, and these are HEDIS measures. And then other conditions would be whatever other condition we looked at in 2013. And so you can see, same thing, the plan in the country that scored the best, and then the total possible points, and you see how the plans kind of stack up against each other. So Evaluate has been a great tool for us to really look at value and population health, because when we ask the plans these questions, we're not asking them specifically about the Verizon employees or the Time Warner employees. We're asking these questions based on their entire commercial book of business. And so it enables us to take a good look at how they're managing the health of their entire population, an entire book of business. So again, we're taking a population health approach to how we're looking at health plans, even though we obviously represent employers who have employees in specific populations. So next slide. So now I'm going to transition to talk about how we use the leverage of the purchasers to drive improvement in value in the healthcare system. And the predominant way we do that is by serving as a neutral convener of stakeholders in our market. And in particular, we have been able to bring the health plans together to work on projects, work on initiatives where, together they're more powerful than they are on their own. And, I don't know how many physicians our providers are on the webinar, but we all know that, physicians and hospitals and other providers are working with multiple payers, 7, 10, et cetera. And any way that we can align the payers to send a common signal and send common priorities into the provider's office, the more successful we'll be on making things happen that we think are important to drive improvement in health and improvement in value. So I'm going to touch on 2 initiatives that we're doing that are multi-payer collaborations that are working on moving the needle forward in terms of improved health and value. So next slide. The first project is related to integrating behavioral health into primary care. And this is clearly something that I think, for the most part, our country has agreed is extremely important, and that we can't separate behavioral health from medical care, mental health from physical health. But to actually make it happen is not easy, and it's fairly challenging. So the reason why the business group focused on this area is because when our employers look at the conditions that impact their employee population, the top 4 or 5 are generally cardiovascular disease, diabetes, musculoskeletal issues, cancer, maternity if you have a certain age population, and then mental health and depression. So as we started looking at this issue, it's interesting, Evaluate actually led us to address this issue of behavioral health in primary care, because one of the questions that the Evaluate tool asks health plans is, how many people in the plan have you identified that have depression, that have a diagnosis of depression? And the first year that we did the Evaluate RFI and asked the question of the plans, the answers came back 0.4%, 0.8%, and here I am thinking, oh, it's the first year, the plans are filling out this RFI, that, oh, they don't understand the question, like they're putting the decimal point in the wrong place. Well, come to find out, the plans know exactly what they're doing, and that was the right answer. And we all know that the prevalence of depression, it's 8, 10, 15%, whatever number you subscribe to, it's way bigger than 0.4%. So this is a huge red flag, and we started investigating this issue. And we discovered, as many of you know, that 80% of antidepressant prescriptions are written by primary care doctors. And when we started talking to primary care doctors about this, we found that there is a great need for support. And there's a lack of knowledge about how some of the medications work, and how to transition a patient from one to the other. And so there's a lack of knowledge, but there's also a lack of a network or referral base in mental health. So most primary care doctors, they have an endocrinologist, they have an orthopedist, they have a cardiologist, they have people they can refer to, but when it comes to mental health, they don't have that network in the same way. So we discovered a proven model called the collaborative care model, and it has been shown to work in communities like group health on the West Coast has implemented the collaborative care model. Minnesota has implemented the collaborative care model, and it's linking a care manager and a consulting psychiatrist to a primary care practice. And if you think about those 2 markets that I mentioned where this has been proven to work, group health is an integrated model, and Minnesota we sometimes call it New York Planet Minnesota, because it's so different, it's so collaborative. They have nonprofit regional health plans, they have large medical groups, and they were able to collaborate on, the plans were able to collaborate on putting care managers into these large medical groups in a way that when you look at a region like New York and many other regions in the country where we have smaller practices and we have large national for-profit health plans, it's more difficult and it doesn't quite work the same way. So even though we know that integrating behavioral health into primary care is critically important and it has an impact, there's no way to reimburse for it. There's no way to reimburse for the model where you have basically, the for-profit national plans, you have a predominantly still fee-for-service environment. So what we've set out to do is to create a multi-payer reimbursement strategy around the collaborative care model. So next slide. So we are in the midst of this. It's been a bit of a journey. We've been working on this for a couple of years. We have Aetna, Cigna, United, Anthem, and Emblem at the table, and we have 4 primary care practices that we are focused on working with and launching in 2015. And the focus is really where the rub comes on reimbursement is paying for things and activities that plans don't normally pay for. And those happen to be the things, the activities that occur when the patient is not present. So for this model to work, we need the care manager to be able to speak with the primary care physician. We need the consulting psychiatrist to be able to speak to the care manager and the primary care physician. So all this coordination among the professionals does not normally get paid for and is critical to making this model work. So we are working with those plans to come up with a reimbursement model that will facilitate the 3 professionals who are coordinating the care of these patients with depression, to improve and to, get better. So I hope maybe to come back in a year or so and give you the results of that. Like I said, we're still in the midst of it, and we are able to get the 5 plans to the table because we represent their customers and we represent, the businesses in the community that think this is very important. So the next project that we're working on is on hospital readmissions. And this is also a multi-payer project, and we brought initially employers, hospitals, and plans together to talk about the problems around readmissions. And where we ended up was that we decided that what we needed to do was bring multiple plans together with one hospital system to work with them on further reducing their readmission rates. So we have Aetna, Cigna, United, Anthem, and Emblem. These are the 5 major plans in our market, downstate New York. And we're working with NYU Langone Medical Center. And again, this is a work in progress, so again, I hope to come back to you in a year with some results. We're focusing on risk scores and coordinating care. What we have learned is that NYU receives risk scores from the health plans on patients that are at risk for readmissions, but they only receive them for a few patients that are either tied to certain payment arrangements or contracts. But what they really like to do is receive them for many more patients. So we're trying to work out all the plans sending risk scores to NYU so that they can better manage those patients at risk for readmission. And then the other piece of this is that what we find is that there are a lot of activities on both the health plan side and the hospital side that are focused on preventing the readmission when the patient leaves the hospital. So what we have a situation where from an employer perspective, we have a patient who when they go home gets a call from the health plan, gets a call from the hospital, and possibly gets a call from the third-party disease management company or the third-party vendor that the employer has hired to work on these things. So what we're trying to do is look at the set of activities that each stakeholder is performing around that readmission reduction activity and figuring out how we can streamline it and not duplicate effort. So what are things that the plan can stop doing that we can have the hospital do, and vice versa. And what we find is that most people don't really want to hear from their health plan when they are sick and they've just gotten out of the hospital. They think the health plan wants to talk to them about their bill, and the health plan is often not that successful. So if we can direct more resources toward the hospital so that they can do more of this, we'll likely have better success rates on reducing readmissions. So, okay, so lastly, I think this is really close to my last slide. I just wanted to highlight for all of you that we're addressing other issues in a multi-stakeholder fashion. We have something called the Solution Center, and this is an example of some of the reports that we have released from the Solution Center, all based on bringing stakeholders together to focus on the population, the health of the population, and specific issues that are extremely challenging. So this first one, which is probably hard for you to read, but is on weight control. That's our newly released report, and you can go on our website to download these. The second one is hospital readmissions, which I just spoke about, value-based benefit design, the phase 1 of our weight control, and pain management. We are in the process of getting ready to release our diabetes report on our diabetes work, and our next set of activities is going to be around cancer. And our website is NEBGH.org if you would be looking for these reports. So why don't I stop there? Maybe we can open it up for questions, and I hope that gave you a good snapshot of what a coalition is doing to move the needle on population health and improving healthcare delivery by grouping employers together and using that collective leverage.
Great. Thank you so much, Laurel. This has been absolutely fascinating. I think that you've generated a lot of questions. So before I jump into the questions, though, moving on to the next slide, we have another upcoming webinar on population health that's going to be on December 18th at noon, and this webinar will examine how population health management interventions help state Medicaid. So that is coming up. If you're interested, you'll be receiving invitation for that in the near future. We have a couple of questions here, and the first question that came through really is directed, I think, to both of you. It's a question I get all the time. With the complexity involved in your topics today, why are employers engaging in these activities, and why don't they just jump to a defined contribution model?
David, do you want to take that first?
Sure. They have a primary concern about the well-being of their workforce. They've spent a lot of money, energy, programming, time over many decades trying to strengthen the health and welfare of their employees with a lot of methods. They're really not confident that abandoning people to a defined contribution or an account-based program will leave there enough leverage in the market to improve the healthcare system and improve the health of their workforce. So I think it's largely, at least for these large employers that I work with, and they have much more resources than many other employers do, they really think they add value to their employees' lives by being activists. The tension, honestly, is that the people I work with are people very close to the health benefits programs who believe in it, have worked their whole careers in it. They're under pressure from people who are more finance-driven in the company who ask the question that was raised here. So it's not a resolved issue. And I think the burden is really felt by my members to demonstrate that the value they think they bring is really measurable and palpable. Laurel, what do you think?
Yeah, I would agree with that, absolutely. And I think the elephant in the room here is this whole issue of private exchanges. And private exchanges is what really enables a defined contribution model, and is clearly something that employers are looking at. But to David's point, I think that a private exchange is really just, it's a benefits administration play, and it doesn't do anything about the true cost of healthcare, which is what's happening at the delivery system. And, we've had some of our members, we think we spent a lot of time educating our members about this, and you know, I was very pleased when I heard one of the, you know, when one of them said, you know, the private exchanges don't do anything about the real cost of healthcare, which is what's happening at the delivery system, and that's what we have to change. And private exchanges don't do anything about that. Defined contribution strategy doesn't do anything about that. And I think that the companies that David and I work with, as he said, are committed to the health of their employees, and in addition, you know, goes hand in hand, the influence and the change in the delivery system to make it better. But you know, I know every CEO or CFO has asked their benefits folks to look at this as a strategy, so it's something that, you know, I think they're tracking, but it doesn't accomplish most of their goals in terms of improved health and in healthcare delivery.
Wonderful, thank you. And to dovetail off that question, I'd be interested in both of your perspectives on what you see as the biggest challenge for the employer-provided system today.
The biggest challenge for the, what'd you say, Adam?
The employer-provided system as a whole today.
You mean our employer-sponsored healthcare system?
Yeah, the continuation of employers providing benefits.
Yeah, well, I mean, it's, you know, as employers most of my employers are competing in a global economy, and, you know, the biggest challenge to the system we have is the impact on cost, and when employers are competing with other companies globally that don't have those costs, it puts them at a disadvantage. And I think employers are going to have to look closely, you know, going forward about how does that impact, you know, their competitiveness and their financial health. And, you know, I think that's certainly something that, you know, impacts how we view employer-sponsored healthcare, because it affects our companies financially.
Great, thank you. And David, do you have any comments on that?
I agree 100%.
Okay, great. So we have a little bit, to jump around a little bit, we have a little bit more of a specific question dealing with readmissions. Readmissions are a key component to the success of patient compliance. Aside from educational efforts, what other options have been proven to be successful to reduce or eliminate readmissions?
So what we're finding in through our project is that where there has been the most success, there has been concentrated and consistent follow-up at home with the patient. So what that means is, you know, a visiting nurse service or some kind of support that happens right away and happens at home, and that is connecting the patient consistently to a resource and to someone that can help them navigate what they need to do. And in our conversations with the health plans and with the hospital, we are talking about how we can facilitate that for more patients, and not, in some cases, not send them to the skilled nursing facility where, you know, people are so quick to, you know, providers are so quick to send patients when they have, you know, an episode in the hospital that requires, you know, watching and consistent oversight, because that's expensive and often not very successful. So we're really focused on how can we get more resources at the home to the person when they leave. And that helps with compliance, because if you have somebody checking in on you and somebody who's constantly in touch with you, face-to-face, or really, you know, someone that you get to know, we know that patient compliance improves. So that's, I think, where we're thinking about putting, you know, some of our efforts is focusing on that.
Yeah, I'd say we have a program we call the California Quality Collaborative, which operates a readmissions reduction program statewide in California, and it's been very successful in a couple of the key features of our work. One has been convening hospitals and medical groups, community ambulatory groups together to talk about coordination between the inpatient and outpatient settings, and then rolling that back into discharge planning and patient communications. But just being the convener of that conversation, where traditionally they were operating in silos, has been an important function for us. And the second thing we've observed is a very close correlation between reduced readmission rates and improved patient communication in the hospital, and therefore strengthening what's going on in the hospital workflow to deal with discharge planning and family and patient involvement, caregiver involvement, has been a big piece of that, and it correlates really well. But people can go to our website or under calquality.org and see a lot more detail about the readmissions program we do.
Great, thank you. And to sort of dovetail off that question, you guys have both identified employee satisfaction as a very important metric in terms of implementing population health. What would each of you consider the top drivers of employee satisfaction when it comes to health coverage?
So I would say, and this kind of flies in the face of what, David, I think, talked about and some of what I talked about, is employees, they want to be able to see whatever, physician or hospital they want to see, so broad access, which doesn't necessarily lend itself to value-based purchasing, but that's probably, I think, the biggest driver, broad access and, not a lot of out-of-pocket costs. But that's what drives employee satisfaction, but I think that's not, it's not attainable for us to keep meeting that satisfaction into the future. I don't know, David, what your thoughts on that are.
Yeah, I agree with you. It's a challenge for our members.
Yeah.
But I'd say there are two paths here. One is, as you raised it or framed it, Adam, the insurance coverage patient satisfaction is driven the way Laurel just said, with a very strong emphasis on cost. But the care satisfaction, the patient experience of care, is also a big value for a lot of my members who, in their own corporate strategy, so a company like Apple or Nordstrom, they really see the person's experience for their own customers and their business side as a really high value that they focus on, and they want that to be translated into the healthcare experiences that they're buying for their employees. And it's been a challenge to have the healthcare industry kind of come to terms with that expectation that all of us as consumers have. When we get on an airplane or go to Nordstrom's, we have a certain expectation about what we value. The employers want that same expectation transmitted to the healthcare system and recognized in payment and recognition programs. So on the care side, it's really that strong sensitivity to what makes the patient engaged in their decision-making, engaged in their care. Ultimately, they'll be more adherent to recommendations, more informed about their health and how to manage their health. Just as an example, we operate a high-need, high-risk chronic care model for very sick people, and the best predictor of lower cost in that program is whether patients do well on what's known as the PAM score, the patient activation measure, that they have really come to understand their own care. So that kind of attention to patient understanding and engagement is a real value for most of our members.
Great, thank you. And to touch upon another facet that was common in both of your presentations was transparency. And how important would you rank transparency in providing purchasers, consumers, and providers of healthcare with the tools that they need?
Go ahead, David.
It's been a huge focus for us for 20 years. In the mid-90s, we started doing the first websites to show consumers their information about HEDIS scores and so on. It's still a very high value. I think it's changed because there's been such broad uptake of this topic by public agencies like CMS and by commercial players like Healthgrades and Castlight, that I think there's a sense now that the data is beginning to flow, and it's not there yet, but it's moving, and there's a public policy dimension to this course. But the issue now is, how do you get consumers to use it effectively, and how do you get purchasers to use it in ways that influence the networks they create and incentives they offer? So our interest has shifted more toward use and less toward production of data. You know, most of the companies you talk to who have access to either plan-sponsored or third-party transparency tools are reporting use rates in the 2 to 8% range. So 90+% of people are not using the data that is now becoming available. And you can argue about whether it's the right data or the right medium or format or whatever, but that's the real challenge is, can you use transparency to change the market?
Great, thank you. Laurel, do you have anything to add to that?
No, I agree with everything David said. Yeah.
Sounds good. I have another question, sort of jumping to another topic. How do each of you see your coalition members utilizing health plans in the future, if at all? So what do you see as the role of the health plan in the future?
Yeah, I mean, I think building off of just what David was talking about, I think I see health plans being a resource for data and information and on cost, cost of care, quality, and really giving consumers information to make decisions. I also see that there's always going to be a need for someone to administer whatever the benefit is. And, even when I think, a lot of our employers are nervous about working directly with providers because of, thinking about who's going to do the administration and how's that going to work. So there's always going to be a role for health plans in doing the administration, as well as I think some of these tools. David, I'm sure you probably have some other thoughts as well.
Well, I agree with the general sentiment. There's a really important role for plans in the ways Laurel just summarized. Also, a lot of our members have large regional or national scope, so they need someone to administer a network that encompasses a lot of geography, and they want the plans to be the strong implementation arm of the strategy that the purchaser is putting forward. So I think the challenge is that the large carriers have many business lines and relationships to providers, and so they don't execute a particular strategy that a company might say, here's what I want to do for quality criteria or for consumer engagement or benefit design. And it's very hard then for a national carrier to customize. I think you saw in Laurel's bar charts from Evaluate, that plan design customization thing is really tough, given the plurality of employers out there. So the employers, in some ways, find it easier to go direct, but they can't scale that. So they really need the plans to find a way to scale innovative designs at a larger level.
Great, that makes perfect sense. Because we're basically on the eve of the employer mandate, I wanted to get each of your perspectives on what do you think the biggest impact the ACA has had on healthcare reform initiatives of employers, and with the new Congress, what you could see being done to really help drive these innovations in the future, if there's anything that can be done from a legislative perspective.
I mean, I think the biggest impact on ACA on employers has been the Cadillac tax, the excise tax. I think it's completely it's completely made employers think about how they're going to, reduce the cost of the benefit. What is their philosophy on It's completely made them rethink their strategy around benefits. What is our philosophy about offering benefits, and how are we going to respond to this new requirement? And that's where, we see employers thinking about private exchanges and saying, I'm going to go to a defined contribution approach, or if they're not going to do that, they have to become extremely committed to the things that David and I talked about today. They have to be extremely focused on improving health, improving healthcare delivery, getting employees to be better consumers, really going all in on how they're managing the health of their employees. So I think the ACA has really had, really made them look at their benefits and what they're doing in a way that they've never looked at them before.
Great, thank you.
Yeah, I absolutely agree. That's the top impact for our members, too. The only additional thing I'd say is all the little things buried in the ACA that collectively point to delivery system reform and CMS's efforts to implement a lot of those models has a collective impact on the market. I think the conversations we're having today are really different than 5 years ago with the provider community. And I think people out there really do understand that the world is going to change now. For us, what it means is I spend almost every day talking about public-private alignment and how to get what CMS is doing and what our members are doing or what the states are doing or state purchasers like CalPERS are doing to get those to point, as Laurel said this earlier, send the same incentive signal so providers are not getting 6 different directions as to how to implement re-engineering and new payment models. So that's a new an impact of ACA is the growing alignment of payers toward a consistent expectation of the delivery system.
Wonderful, thank you. And I think we have time for one more question. Can each of you comment on the capacity of measures of indirect costs such as lost productivity, presenteeism, absenteeism to drive your value-based purchasing initiative? And assuming that is substantial, what is being done to make the needed data and expertise more available?
Yeah, this is one of those things that, it's a little, despite all the conversation and thoughtfulness and very good work done on this area, our members are very, they're sympathetic, but they're not excited about it. I think they feel an accountability to manage hard dollars. And my last meetings, the last couple of weeks with some of my members, they really come back to Laurel's point about the Cadillac tax, that they feel pressured to document direct dollar spending on, on external benefits. And this area is one that they understand and do some work in, but it's not compelling.
Great, thank you. Laurel?
Yeah, no, I mean, I have the same answer. We have
okay.
Members, we have the same kind of members. So.
Wonderful, and I think we're probably out of time, so I just want to thank each of you. This has absolutely been a fascinating journey through this, and thank you for participating. We really appreciate it, and thanks to everyone who dialed in. I think this is very productive, and I think this will drive how employer benefits are offered in the future. So thank you guys so much for participating, and I will turn it back to our admin team.
Thank you.
Thank you for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.